Welcome everybody to this edition of Macro Pro and Friends. My name is Diane Cohen and I'm here with Dr. Amanda Wilson. Hi doctor, how are you today?
I'm well, Diane. Thanks so much for inviting me to participate in this. I'm very excited to be here.
Well, we're excited to have you. So I met Dr. Wilson at the National Disability and Workers' Comp Conference in Las Vegas. And the minute I saw her program, I knew that we had to have her on our webinar series because what she does is truly incredible. But before we get in that, I'm going to do a little bit of housekeeping. So today's webinar is worth 1 California CEU credit. You will be receiving your certificate within 1 hour of this program, but you must be logged onto the program and use the link that we sent to you. If you just phoned in, unfortunately, GoToWebinar cannot time your time and attendance, so they need to be sure that we have that clicked on to make sure that you get that credit. All right, there are handouts for today's program and you can download them. They are on the control console, so just go ahead and download that. If you have an issue with that, you can let me know and I'll be happy to send that to you. And then lastly, this program will be on the Macro Pro YouTube channel, so be there early next week at the very latest. It could be there as soon as Friday. If you have questions for Doctor, you certainly may ask them. And somebody is texting me. I just want to make sure that there's nothing wrong with my audio, and people are saying that. Nope, there's nothing wrong with audio. Thank you guys. I see already we have some very nice compliments and people are looking forward to this program. So, Dr. Amanda, you originally started this program after creating something for opioids. So can you tell us a little bit about your background and how you went from opioids into working with people with alcoholism?
Sure. So it's a pleasure to meet all of you and so glad you could attend today. My background, I'm an internal medicine physician, but I'm also board certified in addiction medicine. Back in 2009, I was running a small community hospital back in Massachusetts. And interestingly, that was really at the start of the growing opioid epidemic. People weren't really aware of it yet, but as a physician, I was really noticing it in our community. So I decided to launch a company, and that company is called Clean Slate Centers. At that time, it was the first of its kind, the very first office-based opioid treatment program. You may have heard of OBOTs before. It was the very first of its kind because we weren't in a community health center or a federally funded health center. It was an independent organization simply devoted to taking care of patients with opioid use. We opened our doors and had an incredible rush of patients because our mission was to take care of all patients and get care to people who were on Medicate and weren't able to get care from any physicians. So we grew very, very quickly. Clean Slate now has 83 centers. It's all across the country. At this point, they've treated more patients with opioid use disorder than any other company in the country alone. In 2014, after getting the company up and going, I decided to found a not-for-profit, and that not-for-profit is called the Addiction Research and Education Foundation. We had so much data from taking care of so many patients by that point that we felt an obligation, a moral and ethical obligation, to share what we had learned about what quality care looks like and how to do that well. So we joined forces with Columbia University. We conducted numerous studies. We're still partnered with them. We've now published 15 peer-reviewed journal articles, all of which have been used actually across the country to influence and implement policies and procedures about how to do best quality opioid use treatment. One of the things that we learned as we were reviewing our own data was that one of the best ways to treat patients with opioid use was to retain them in treatment as long as possible, actually. We found that we could achieve a 91% success rate treating patients with opioid use if we had them in treatment for 3 years. So we started looking at tools to retain people in care. And one of the things that occurred to us, even though it was early and people weren't really using this yet, but we thought telehealth might make a big difference to make things.
You guys were cutting edge of it for that. It's something we see every day now, but you started that when?
2017. So, 5 years ago, and really at the time, people thought that, frankly, that I was a little nuts. How are you going to take care of patients with opioid use on telehealth? But it was quite successful. We founded a company called Boulder Care. That was my second company. That was the very first telehealth opioid use treatment company. That company has now treated about 20,000 patients. It's also providing care across the country. They provide care for all Amazon employees right now. So Boulder's grown very, very quickly as well. So I built that from 2017 to 2020. In 2020, of course, COVID hit. And right away, we were seeing headlines about a really significant bump in alcohol consumption. And my co-founder with For Boulder and I, Dr. Shido, we decided together, no one's really innovated in the alcohol use space in 90 years. Really nothing has changed about the way treatment is done, about what types of care people receive when they go to an inpatient center in rehab or when they go to detox. There's just been no evolution in that treatment. We're using medications readily now in opioid use treatment, right? You've probably heard of medication-assisted treatment. But medication-assisted treatment hasn't been implemented in alcohol use. So we decided to conduct a very deep literature search. We reviewed 2,000 papers. We reviewed every single peer-reviewed article that had been published on alcohol use disorder since the year 2000. And in doing that, we uncovered several key, really important things that I'm going to share with you today about how alcohol use can be done and be done well and effectively. So I look forward to telling you all about our program and talking about how this could be helpful for employers, for workers' comp organizations, so that we can all help people be more healthy.
So as you know, doctor, you and I have spoken about this before, but not all of our audience know. I'm the daughter of an alcoholic and a mother of an alcoholic.
Yeah.
And your program is so revolutionary because it can change a family's life. It's weird. You think you could get used to that statement, but you never do. But, one of the things that happened for me that was really, really surreal was my son was in a drunken stupor, and we picked him up from somewhere, and then we decided we needed to take him and have him treated. So we're in the car driving, and I've got Bluetooth on because I'm trying to talk to the 911 to call the hospital so that they can meet us at the emergency room. And meanwhile, there's lots of chaos in my car. My husband's in the front seat, my son's in the back seat. My son's decided he's going to jump out of the car while we're driving. And I've got people talking to me from the Bluetooth speakers, and my son and my husband screaming and all the noise. And my son's like, at the time, he's 6'2", probably weighed 240. My husband is 5'8" and 170 maybe. And, he's holding onto my son's one arm from the front seat, trying to keep him from jumping out of the car. And these are situations that your program hopefully will eliminate. And I pray that for every family or anybody listening that may even have their own problem and it's not workers' comp related, this is an amazing program. So let's talk a little bit though, doctor, about, the program and the effect that it has on the workplace. Do you have some stats on that for us?
I sure do. Yeah. So our company is called North Star Care. And I'm just going to dive right into why it is that this is so important in this space. Why is it really helpful and relevant to talk about this with respect to workers' comp? The thing that I think is not well known yet is that, and this is the US Department of Labor's statistics. So this is, you could Google this and find it quickly, that 65% of all workplace accidents are actually due to alcohol or drug use. And so, as people come in and have had injuries in the workplace, I think that it's unfortunate that while we often test, right, to see whether they have alcohol in their systems or not, what happens to that person after that is generally they're not referred into treatment. And if they are referred to treatment, what I'm going to share with you later is unfortunately the treatments that are out there today don't work. So those same people, I've come to learn that two of the biggest fears after an injury in the workplace are on the behalf of the injured person, they're afraid they'll get injured again. And of course, on behalf of the employer, they're afraid that there's a risk of that same injury occurring or the same accident occurring. So, to alleviate that, we have to have effective treatment. And we have to get people into treatment quickly. If someone had an elevated blood sugar and it caused some confusion for them and they had an accident in the workplace, we would definitely get them in with a doctor who could manage their diabetes, right? And so that's what I'm suggesting here is that we need to be really thoughtful about detecting people who might have this problem, trying to get them into treatment early, because the goal here is that if we can treat people early, we can avoid all kinds of challenges that they're likely to face, and workplace injury, which of course is on the top of everybody's mind. When people have an alcohol use problem, they're actually 3.6 times more likely to have an accident. And 47% of industrial accidents actually involve alcohol. So, it's just such an enormous contributor, clearly, to workplace injury. If you're in warehouse and manufacturing, you have a 270% more chance of having an accident if you're on alcohol. And most employees will report that not only are they, of course, we know that they're at risk of higher injury, but they're also inefficient at work. And for the employers that you're all working with, it's really important. You want to be sure that we're maximizing those employees' ability and efficiency, their presenteeism at work. That really matters to the employers that you work with.
Absolutely. Those are staggering stats. I don't think that people really think about it. We are constantly working on claims and taking care of injured workers and doing what we need to do, but I don't think we ever break it down and say, this is the percentage that alcohol has on our workforce and our claims. And it is something that with help, we can certainly reduce those numbers.
That's it. No, there is a treatment now that's effective. And that's what I'm excited to share with you. People also don't know that there are actually 28 million people who suffer with alcohol use disorder. I'm going to share a different slide in a little bit that talks a little bit more about that. But this is a massive problem. This is almost 10% of the country, and it's up to 17% of the workforce has alcohol use disorder. So those numbers are staggering. If nearly 1 in 5 of the employees in an employer that you're working with are struggling with alcohol use, you can imagine what kind of cost that implies for that employer, what kind of challenges those employees face, and what the risks are. 300% more cost for medical care for people who suffer with alcohol use disorder. Again, we talked about a much higher incidence of accident or injury. And what people don't know is that on average, they miss 32 days a year of work. The average, I know it's staggering, the average number of sick days for someone is 11 days. So this is 20 days plus more lost work days because of severe alcohol use. What I'd like to talk about that I think also is really important to know is that alcohol use most people know that it'll cause liver problems, right? It'll cause liver failure or cause hepatitis. But they don't know that it causes many other problems that are actually more severe. And in fact, if you look at how much someone drinks, if someone every single day drinks 2 drinks, moves to 3, moves to 4, they haven't necessarily got an alcohol use disorder yet. The disorder implies that they just can't go without it. So they might typically drink 3-4 drinks a day, but they could go a weekend without drinking. And they're not craving it all the time, and it's not out of control. So by definition, they don't technically have an alcohol use disorder yet. They just have an overuse. So the amount of alcohol that you consume actually has more of an impact on the risk of cancer than it does on the risk of you developing an alcohol use disorder itself, which I think is shocking. Yeah.
I never would have put the two together. That's incredible.
Yeah, all kinds of cancer, breast cancer, colon cancer, liver cancer. I mean, the number of cancers is astounding. You have 5 times increased risk of esophageal cancer if you drink alcohol regularly. So cancer is like the number one. See how dark that arrow is? It's one of the darkest arrows on the screen. Very strong relationship with high levels of alcohol consumption, and much stronger relationship with cancer than with liver disease, right? A different significant effect on infectious disease because you're suppressing your immune system, so you get more pneumonias, other infections are really prevalent. So if people just binge drink, let's say they just drink heavily occasionally, that even increases their risk of infectious disease pretty strongly. It also increases their risk of heart disease, cardiovascular disease. So when people are landing in the hospital with heart disease, either heart attacks or cardiovascular disease, largely it's because they've had heavy drinking episodes. I'll give you an example. I don't know if you've heard of this before, but when people have been, participating in a holiday, Thanksgiving, Christmas, the day after, generally they'll land in the hospital if they've had enough to drink. A big heavy drinking episode the night before causes what we all call holiday heart in the medical terminology. Holiday heart is people at day after Christmas land in the hospital because their heart rhythms go completely out of whack because of a heavy drinking episode. So it doesn't
And
have to be daily.
I don't think people normally associate, their heartbeat with drinking.
Yeah,
And so I can imagine functional alcoholics must really have a time with that.
they do. And they'll land in the hospital, or they'll land, they're basically, having trouble at work. They might get into a heart rhythm problem because they have an alcohol issue and they're stressed, and they end up in the emergency room, right? And that emergency room cost is exceptional, and leads to why there's such a significant increase in medical costs for people who have alcohol use disorder. If you see AUD in this presentation, it's referring to alcohol use disorder, which is what we call it in medicine today. So just overall, what is alcohol costing businesses? Where are the risks to businesses? Absenteeism, I've already talked about that. Very increased employee turnover, because many employers, unfortunately, if someone's identified as having this problem, instead of helping them get treatment, they'll often just dismiss that employee. And, I like to think about the fact that employers want to keep their best employees. And interestingly, the folks who have this problem, more often than not, are managerial or high-level employees. They're actually the people you want to keep. It's the people who work the hardest, they're stressed, they're compensating their stress by drinking, but they're often high-level employees in an organization that if you lose them, trying to replace them is very, very difficult. So we've talked about increased healthcare costs, increased insurance premiums because of workplace accidents. Obviously, there's interruption in the employee's work effort. They may be drinking at night and not drinking at the workplace, but the impact the next morning is very real on their efficiency and their presenteeism. Of course, increased legal fees, increased workers' comp claims, increased employee conflict. People come in agitated and not feeling well the next day. They're not necessarily going to be on their best behavior. And then a higher rate of damaged, corporate equipment. So we did a calculation just trying to figure on a, small to moderate sized company, say 1,500 employee company. Average missed workday wages alone for that company for 1 year, almost $1.5 million.
That's a
Just
tremendous amount of money.
just that. It's a lot of money. Yeah, just for that one thing, just the missed workday wages. So this is a huge cost. It's just not being addressed, and it's just majorly under identified.
How does that compare to like opioids, for example? How does that work?
Exactly. So, opioids get a lot of the press right now. There's a lot of attention on opioid use disorder, and clearly I've dedicated the first 15 years of my career in addiction medicine on opioid use disorder. I'm very passionate about it, very concerned about it. But that being said, the alcohol use disorder problem is 10 times bigger. So if you look at this sort of picture of people here, the yellow people here would be the number of people relatively with opioid use problems. All of the folks for the rest of this page here are all people with alcohol use, just to give you a relative feel for how many more people struggle with alcohol use than with opioid use. We then wanted to describe, well, how many of these poor blue people that have alcohol use disorder, how many of them are getting any treatment at all? So that's represented here in green. So you can see the very vast majority of these blue folks aren't getting any treatment at all. When they looked at who was getting treatment, it turns out that this group included people who went to prison. They called that treatment.
That's
Called it
treatment.
It's not treatment, exactly. They called it treatment if they had gone to their primary care doctor that year. That's not treatment. They called it treatment if they went to the ER. That also is not treatment.
No.
So this included, AA, it included rehab, it included detox, but largely it was looking at a whole host of different types of healthcare that could not be construed as treatment. So I don't even agree that this many people are actually getting treatment today. And this one little red person down here would have been the only person with all of these people with alcohol use disorder who were placed on a medication to treat it. So
Wow, that's really significant that it is under prescribed. Now,
underprescribed.
yeah,
Yeah, not even. It's at this point, before Suboxone, buprenorphine came out and became available for treating opioid use was treated the same way. People went to detox, they went to rehab, they came out and they had a very poor success rate. And once these medications became widely available, we realized that actually the standard of care needed to be using medications for this treatment. I'll liken it in some ways to cancer treatment. we obviously all believe and know that support groups for cancer are incredibly helpful, right? It's very, very helpful. But we don't think of a support group for cancer to be the treatment, right? When you go to get treatment for cancer, you have a multidisciplinary team. You have a physician, you have a nurse, you have a nutritionist, you work with your primary care doctor, and you might have a support group. But the support group is not the mainstay of treatment. And today, most of these folks, the only thing that they're having access to really is a support group. And obviously, very few people choose to do that. All of these people in here agree. Some of them chose to go to AA, but none of these people are choosing to go. And the reason I think is anonymity. One of the things that AA is not is actually anonymous.
No,
And so it's not. Yeah. So when you
and
go
one
in
of
your
my colleagues, was saying that they a friend of theirs went into an AA program and came out, said, I can't come back there because they're people that I know. Now I know that they have a problem and they know I have a problem, and I'm so uncomfortable because I thought I wouldn't know anybody. Of
exactly.
course, alcoholism is huge. And
So
so, you probably are going to meet somebody at one of those meetings that,
yeah.
you're either going to bond because of it, or you're going to fly. You're going to flee, right? You're not going to go back, which is very unfortunate.
Yeah, that's why we started looking at how could we provide a truly anonymous way to do group support. And when we talked to patients who had gone to meetings, one person told us that they went 3 towns over, intentionally hoping to not run into someone that they knew. And when they went 3 towns over, they still ran into a cousin and an immediate family member. And they, because they had also gone 3 towns over trying to find a meeting where nobody would know them.
Right.
So
And a little bit later in this presentation, we're going to talk about how your program truly is anonymous and nobody will ever, ever know who's in that meeting. So I think that's fantastic.
yeah,
So do you have some numbers like on COVID and drinking and that type of thing?
I do actually. COVID was what inspired us to build this program, knowing that so many people were suffering and that it was getting much worse. And so the impact of COVID on alcohol use has been substantial. It's still 54% increased use since COVID, 54% increase in alcohol sales. And when it's being sold, it's being used. So we know there's a gigantic increase in use. Now 1 in 5 Americans are drinking unhealthy amounts of alcohol. That's an alarming number of people. And the group that was hit the worst, honestly, with this, were actually moms with young children, women with children under the age of 5. That group had a 323% increase in alcohol use. That's a startling number. It was almost twice the number of minority people who had an increase in use also. It was the key group that went up. And you can imagine why. If someone at home was drinking, a couple of glasses of wine a night, suddenly they're isolated. Now they're trying to work from home and manage their children. They can't put their kids into daycare. The strain on young moms was just enormous. So they went from drinking a glass of wine a night to a box of wine a night. And that
Wow.
just became highly prevalent. And so it's been one of our missions to really try to increase access to that quality care. When you look on the right-hand side,
I
yeah,
was going to say during COVID too, you mentioned moms, they used to go to work and then they come home, take care of their children, do what it has to do, get them to their programs. Now all of
yeah,
a sudden there's no programs for them to
yeah,
go to. And now they're also a teacher and an
yes,
employee, right? And so I could see why COVID would really have increased the number of people drinking. And, I guess I, on the other hand, will say that my social drinking probably went up, right? Because you can't go out, so you and the husband grab a cup of, get your glass of something and sit out on the patio. And it's sad that unfortunately it went too far for some.
it did. And, this is a genetic disorder. That's what's not well known. Up to 60% of the reason people develop alcohol use disorder is based on genetics. You mentioned your mom, you mentioned your son. It's genetic, it runs in families. So the probability is so high of developing this problem. If you've got the gene already and you start increasing your alcohol consumption, essentially you're triggering that gene to kick in, and you have a much higher risk of converting from just having some regular drinking to having some problem drinking. And that's what people aren't aware of, is this really is a genetic problem. If you have two twins that were reared in different families, if they both have the gene and one twin is raised in a family where there's no alcohol at all, they'll still develop an alcohol use disorder problem at the same rate as their twin did.
That's fascinating. I
Yeah.
mean, we don't really often think of genetics and drinking, right?
Yeah.
We think of genetics sometimes with cancer, right?
Yeah.
Or any other type of disease, but this is the same. It is a disease of a type, and we need to be aware of that. What
Yeah.
about relapses and such? Do we have much information on that, or is that something we're going to cover in a minute?
Yeah, we do. Well, I'll talk about the success rate, and so the success rate speaks to relapse in many ways, right? Because the way that we think about someone being successful is they've gotten control back over their drinking. So AA, unfortunately, this is not well known, but it's clearly in the published literature. They have an 8% success rate, which means that 92% of people who attend AA aren't having success with that, meaning they're having significant returns to use. Detox has a 10% success rate. So on average, people go to detox. I've had patients come into our program who've gone to detox 15 times in the last 2 years. They just go and go and go, and it's not effective. Residential rehab is not much better. The success rate is 13%. And it's very expensive. It could be anywhere from $30,000 to $60,000 for a single month of treatment. And the reason is that when you go to residential rehab, essentially what you're doing are AA meetings. You're in
Yeah.
AA meetings from 9 in the morning until 6 p.m. at night. You're not allowed back in your room. You have to stay out and participate in these meetings all day. And they're working the steps, and I'm not in any way trying to say that that doesn't work for some. It does. And I love that it works for some people. I absolutely respect that this has been a helpful tool for many, many millions of people. It's the other 92% of people who either are uncomfortable because of the anonymity issue or just don't find that that particular method is helpful to them. Many people are kind of put off by the fact that it has a bit of a religious or spiritual overtone to it. So many things push people away. So a lot of people, when they get out of rehab, they pretty quickly have a return to use. The average person goes to rehab 5 times. And they're generally told when they go into rehab, you're going to fail. That's what they're told when they walk in the door.
Yeah,
So it's,
my son was told that he would fail an average of 8 times. And
yeah,
he's just like, stop giving me permission to fail. Because really that's what they're doing. It's like, you're gonna fail, you'll be back. And he's just like, please stop that. It did take him, I think it was 3 attempts before he got clean and sober. Interestingly enough, he was able to get off of opiates far easier than alcohol.
wow, yeah. Well,
And I would have thought it was the other way around.
if he was on that medication that I mentioned, Suboxone, it's miraculous how well that works. It really is. It's profoundly effective. And that's what we're doing with alcohol now. We're using combinations of medications that can make it so much easier to come off of alcohol. It really is possible. So I'm going to kind of go over and compare and contrast, what happens at rehab, what is rehab about, to what North Star is all about, and why we're so different. When you go to rehab, you go away to rehab, right? You're leaving your family, you have to leave your job, you have to tell your boss that you need 30 days off. And people don't generally ask for 30 days off. So when that happens, you're clearly having to announce something about your personal medical care that you might not want to otherwise share. People worry about losing their job, but they do it because they're at a point where they don't really have a choice anymore. They might be at risk of losing their job because someone there already knows they have a problem. They could be facing a divorce. They could have just had a DUI. There's lots of reasons why people go, but generally it's not because they have stage 1 or stage 2 disease. It's because they're at stage 3 or 4 and things have gotten bad in their lives. So you go away for 30 days. Again, it can cost anywhere from $30,000 and some are up to $80,000 for 1 month of treatment. It's not a medical program. It's 12-step based, so you're participating in these AA groups during the day. They have a 13% success rate. All of them require abstinence of everyone. And, for sure, many stage 3 and 4 patients need to be abstinent for the rest of their lives. They have effects of alcohol in their systems, including liver effects or other things, or they've just had a long problem for many, many years and a high rate of use. And for them, a return to use would be very risky. But there are patients in stage 2 or early stage 3 disease who realistically could just get control back over their alcohol use. It's actually widely done in the rest of the world. In Australia, in Europe, helping people regain control over use is much more common than people, going straight into abstinence. But in the United States, people tend to embody or believe in the 12-step model, which basically purports that if you've had a struggle with this at all, you can never have a drop of alcohol again. That's the belief they promulgate, and it's just not true for people with earlier stage. So if you're 27 years old, things have gotten more and more difficult, you're really having a hard time stopping, you're not probably going to go to rehab if you think what they're going to make you commit to is I'm never going to drink alcohol again. I'm not going to drink at my daughter's wedding. I'm not going to, drink when I'm, 60 and, just never again. So people don't go. It's a huge barrier, right, to people going. At North Star, we know that basically treatment from home works, that it's possible to do that, and it's actually easier on patients to do it, much less stressful. Stay home with your family, continue to work. Our program's a year long because you can't treat this disorder in a month. You can't treat depression or anxiety or any mental health problem in a month. So there's no reason to think that you could treat alcohol in a month either. So our program's an entire year. Our program's less than half the cost of a typical rehab stay. And it's completely evidence-based. Every component of what we're doing at North Star is based on large volumes of evidence that we've distilled down and reviewed to know what works and what works most effectively for patients. We have an 86% success rate, so we're doing 600% better than rehab is at this point. We can provide abstinence or moderation as options to patients who are earlier in disease. And of course, people can stay with their families, which we think is really important. So these are all the different components that I'm going to speak about in a little bit more detail, each of them. But every single patient has, care coordination, which is done through our application and with a care navigator that works on the patient's team. We do remote monitoring, so we're able to monitor if someone's continuing to use alcohol. We'll talk about that more in a little bit. We personalize medication treatments to each patient. We use the genetics. We get a genetic panel for every patient. Just like you would, again, if you had cancer, doctors get genetics and decide what treatment's best for you based on that. So we get a genetic panel. It helps us to know, number one, why did the person get the problem in the first place? Number two, how at risk are their children? And number three, what's the best medication to treat them? We can actually know what meds are most likely to work best, so it's not a guessing game. We're making a very targeted and personalized approach for every patient.
Doctor, we have a question. We have a question on medicine. So I'm going to put my glasses on so I can see this a little better. And it says, how effective is antibusin with AUD?
So antabuse is a medication that's been available for 30 years. Interestingly, there's never been a single study that proved it worked. Antabuse is the one medication that we don't use at North Star. And the reason is that the way that medication works is it causes people, if they take it every day, it's basically trying to make it impossible for someone to drink again, because if they consume alcohol, they'll vomit. So we find that to be a rather, frankly, kind of cruel way to help people stop drinking. So the way that we do this is we actually use medications that replace the neurotransmitter in the brain that the person needs. In a way, you could think of it like when people use, a Nicoderm patch, right? They stop smoking, but you're still replacing the nicotine so that over time they can wean off of it and get out of the pattern of smoking every day first. So, and it's of course much more healthy to get nicotine through your skin than it is to inhale, all that comes in with smoke. So same idea with alcohol. We're reducing that risk by placing on medications that essentially replace those transmitters in the brain so they feel normal. They don't have cravings and they're able to stop drinking. It's very effective. And we're not forcing them to throw up when they, have any kind of return to use. So that's the only medication of the medications that are out there that we don't use. And unfortunately, it's sort of a mean way. It would be like, again, giving someone some medication that if they smoked again, they'd vomit. I think that would be kind of a harsh way to treat it. So we don't use that.
So someone had asked a question. I think you're getting into it now, Jennifer. Your question was how, excuse me, I'm losing my voice here. How would you recommend treatment for an injured worker who's self-medicating with alcohol? So I think we're going to go over that right now. So we've got that one covered, but someone's asking about pilots and the success among pilots. Obviously, we want our pilots to not be drinking, and definitely, friends of Bill W. or Amanda, because we want to keep them, skies very safe. Do you have statistics on success rates?
We do have statistics on success rates across numerous categories of patients. I don't have statistics specifically for pilots because we haven't had a large enough cohort of pilots yet. What I can say to you is that pilots that are engaged in a program through their employer, if the program has identified that they have, their employer has identified they have a problem and they've been placed into a program, they tend to have a higher rate of success in treatment because they're highly motivated to retain their employment. So what I believe is that if you now couple that they're engaged in that program through their employer, and now they have a year-long program that also monitors them with a watch. We have a watch that monitors the alcohol level 24 hours a day, 7 days a week. We're going to know if the person's imbibing alcohol or has alcohol in their system so that we can prevent any future accidents. We can prevent any problems because the watch also geolocates. We can know if they're at the airport and they have alcohol in their system. So it's a remarkable way for us to track what's happening with the patient, know when there's incidences of use, prevent further injury down the road. And, much like physician programs, nursing programs that they have for people with substance use problems, the pilot programs that they have for that, I think in partnership with those programs, we could generate a much more effective solution because, as you know, rehab only works 13% of the time. And that's why pilots have a return to use. We need to get them treatment that actually works, treatment that they can take while they're working. There's no reason they can't be flying when they're on the medications we prescribe, perfectly safe. So they can be on medications, be on the nutrients we put them on, and they will be successful. The other thing is that
the beauty of that is, I'm sorry to interrupt, is with that watch that you have, we're not concerned about after hours, right? We're concerned about what they're doing when they're on the job. So you would be able to get that report if they're actually drinking or have anything in their system during work hours. And of course, their own time is their own time.
Yes, yeah. And, we want to know all the times because we want to help them get control over it all the time. So that's why we formed a partnership with a company that makes this watch that monitors 24/7. It only has to be charged once a week. So it's a very effective tool. So we'll keep touching on that. But I think the other thing I want to mention about it is our treatment's portable, right? We use tablets for people to conduct their telehealth visits with their doctors and nurses and the medical team. And we actually use virtual reality for people to participate in their peer support groups. So a pilot could literally have in a bag all the tools that they need to be able to do this treatment anywhere that they're flying in the world. So why don't we move on and we'll talk a little bit about what exactly is happening in the brain of people who drink alcohol and why do they struggle and why is it so important that we treat them? If you look at, this is a normal, healthy firing brain. This represents what a PET scan looks like. It's a scan of the blood flow and activity in the brain. So a normal, healthy brain lights up, has, deep red areas where there's a lot of heavy activity. When someone's been consuming alcohol regularly, high levels of alcohol every day for some time, and they suddenly stop drinking, like as if they went to detox and they've been not drinking now for about 10 days, this is what their brain looks like. It just completely shuts down. There's very little blood flow and you can see very little activity in the frontal lobes up here. And the frontal lobes are where we do our thinking. It's where we anticipate, where we think about the future, where we learn. So when we put people into a rehab setting, they have to abruptly stop alcohol consumption. They're not given any medications to help their brain heal or any nutrients to help their brain heal. They're in a facility for 30 days where they're supposed to be learning. And yet that frontal part of their brain is completely shut down. Learning isn't a possibility.
Well, and even being able to do your job effectively, if your brain looks like the middle, the employer is not paying for a healthy human being. They are getting subpar work out of that person.
Correct, exactly. And even 100 days out, look at what it looks like. So if someone did go to rehab and they've been back and at work for 70 days, 100 days out, their brain is still only functioning at 20–25%. So it became imperative that we look at a variety of different tools to try to improve this treatment. And what North Star is all about is basically providing 12 months of treatment using science. We use genetics, evidence-based medication choices, nutrients, using technology to get this care to people effectively and to monitor them. And we'll talk a little bit more about these. And then doing this in a very compassionate way. Our belief is that this is a chronic disease. It's a chronic medical disease. When someone is diagnosed with advanced diabetes, if they suddenly go off their diet for 3 days and then they go back and see their doctor, the doctor's going to coach them about ways to avoid those things or how to improve their diet or how they can add other things to their diet and try to avoid, heavy ice cream and cake days. But they don't get yelled at. They're not discriminated against. They're not treated badly. Family members don't judge them. So our principle on this is compassion. We hold the patients up when they have a return to use. We support them through it. And we gain their trust and they feel very comfortable with us and they talk freely about when they're struggling. And we just wrap more intense care around them in a very compassionate way. I think by doing that, we are very successful at actually helping people feel like they've got a bond with our team, and that's really what carries them through. So when we did this deep dive and review, we learned that there aren't 1 or even 2 medications that are effective in alcohol use treatment. There are 30. There have been 30 well-studied, highly evidence-based medications available for alcohol use treatment now for almost 20 years. Several have been found in the last 5 or 6, but there's a huge number and growing. So it's unfortunate that this hasn't been adopted, but in general, the reason why medications haven't been adopted in centers that use an AA model for treatment is because AA doesn't support medication use. They often, in fact, tell people to come off of antidepressants. They feel like medications in general are a bad idea. People in my first company, Clean Slate, who used to go to try to participate in meetings because they wanted that support, they would be told during a meeting that because they were on a medication, they were on Suboxone, that they could not speak at the meeting. They weren't allowed to participate. They could just listen. And that I thought was pretty awful. So, we are big believers in supporting patients and getting them, all of the treatment that they need. And we think medication is a big part of how we can heal that struggling brain and help it to return to normalcy much more rapidly and have them be thinking clearer. In addition, we use nutritional supplements, and I'm going to talk about that a little bit more. Most people understand, medications and the idea behind why that works, but I want to take a little deeper dive into nutritional supplements in a moment. We've talked about genetics and how genetics help us to predict which medications are likely to work best for which patients. Also helps us to know how to give nutrient therapies that will really work for people. B12 is a good example. About 20% of people can't absorb B12 when they take it orally, so they need to have it given to them as an injection. You may have heard of people who need B12 as an injection. B12 can cause dementia in patients who have alcohol use disorder. In 3 years, they can develop a dementia from it. So if we don't get their B12 stocked up again, then they're likely to have more cognitive problems and yet again a problem in the workplace.
So let me understand that. The lack of B12 can create dementia.
It can cause an encephalopathy. It's a full dementia just from alcohol use. So it's critically important to replace that B12, and people lose B12 because when they're drinking alcohol, they wipe out the normal healthy bacteria in the gut, and they're just simply not able to absorb B12 in the normal way. So let's talk a little bit about nutrients. I'll just spend time on one of them because it's very often something people aren't aware of, and I think it's really interesting to know. Just this one nutrient that we replace, magnesium, has a gigantic impact on patient outcomes. When anyone drinks alcohol, it turns out that your kidneys start losing magnesium. Magnesium leaks into the urine. And what's interesting is that magnesium and alcohol basically sit on the same receptor in the brain. They cause the brain to relax. You might be aware that we give IV magnesium to women who are pregnant and going into premature labor. The reason we give them IV magnesium is to relax the muscle of the uterus, right? To stop that premature labor. So magnesium is a relaxant. So now your alcohol's worn off next morning, right? And the magnesium level's now low too. So now you have no magnesium on board, you have this anxiety. The low magnesium causes this anxiety, this kind of creepy feeling. It actually causes the symptoms of hangover. And when people feel hungover, their temptation is to, hair the dog that bit you, right? Their temptation is to have more alcohol. They drink more alcohol, they get lower magnesium still. So they end up in this vicious cycle, right? And what can happen when you get low enough magnesium levels, you can have seizures, right? You can have low enough magnesium levels that you end up with heart arrhythmias. That's why people end up with holiday heart in the hospital. You can have low enough magnesium that you lose bone and muscle, bone and muscle loss. You've probably seen people with kind of a wasting syndrome because of advanced alcohol use. So just by taking patients up on magnesium, we reduce their anxiety, we improve their sleep, and we dramatically improve their cravings. And that's just one of the 20 nutrients that we provide to patients. It makes a gigantic difference in how they feel.
It's unbelievable that, one replacement of supplement can do so much for the body. Imagine what all 20 is going to do for them. That's fantastic. Great research.
Within 2 weeks, our patients tell us they would never go off of them. They'll start out saying, I'm going to take how many nutrients? 20 sounds like a lot, to most people, but once they get on them, they fully feel the difference. They feel that they're cognitively better, they can function better. A 27-year-old young man in our program had been drinking heavily for 10 years. He had stopped being able to read 3 years before. He couldn't read a book because he'd read a chapter, he'd forget that chapter, he'd go back to read the next chapter and didn't know where he was. So his favorite pastime, reading, wasn't something he could do anymore. And after being on our supplements for about 3 weeks, he was back to reading books and he was so excited. So it doesn't take long to make a profound difference in brain healing. So I'm going to pivot now and talk a little bit about how we use technology. We've talked about the science. This is how the technology can impact care. I'm going to focus a little bit on that bracelet that we talked about. It looks sort of like a Fitbit. It not only enables us to monitor people's alcohol concentration 24/7, but we also can monitor their heart rate. We know how active they're being. Are they exercising, which we encourage? We know whether or not they're sleeping well or not, because all people who struggle with alcohol use have sleep problems. So we address their sleep problems with different medications and nutrients. And again, we know where they are. We know if they're drinking and driving, for example. We would know if they're drinking and flying. It's important to know that. So we have that geolocation. So this device gives us a ton of information to help us manage patients really effectively. We've built our own application. The app is really just to make care coordination for the patient very simple. They can talk with any of their providers. Every patient has a doctor, a nurse practitioner, a navigator, and their very own peer guide. Every peer guide is someone with lived experience. They're folks who themselves struggled with alcohol use, and they're there to sort of share their life experience with other people who are now struggling to help them get through it and learn from that.
I think it's brilliant here. I'm looking at the slide here, and you've got a chat now. So somebody's at work, they're having a breakdown, or, somebody said something or whatever the case is, and they're like, I need to deal with this. Everybody picks up their phone and everybody uses it. So if they got on the phone and pushed that button and chatted with somebody anonymously, nobody would know that they were getting support for an issue. So
Right.
I think this is really fantastic for employers, because their employees have access to something immediate that can help them in the middle of their crisis, as opposed to saying, the heck with this, I'm going to the bar during lunch and I'm going to self-medicate.
That's
Fantastic. Really great technology.
Thank you. And I think the other piece to know is that this care can be done in the evenings, on the weekends. We really work around the patient's schedule because we want to keep them employed. We want to keep them being successful and moving forward in their life. That gives them reward and purpose. It's really important to help them, to support them in that. So all of our team care can be worked around the patient's schedule. And that's why we provide them with a tablet if they don't have one, because on their work hour, instead of going to get a drink, they could actually go out to their car and have a meeting. They could meet with their peer and talk to them about how they're doing. So we want to be in constant contact with them, and they really are in constant contact with our team. And early treatment, our patients are in contact with our team up to 30 hours a week in the very beginning sometimes. If they really need a lot of intensive treatment on the weekend, they could be on the phone literally 10 hours a day. So they're getting a lot of intensive support when they really need it.
And it's all inclusive.
Yeah, go ahead.
And it's all inclusive. They get that included in their program.
Completely included. Yeah, 100%. And I'll mention this monitoring device. This is a tool that the company that makes these watches also makes. These can be mounted at a place of employment. So factory floor, we talked about how that's a place where there's high incidence of injury. These could be mounted on a factory floor. You can detect if someone has alcohol in their system in 12 seconds. So you mount this device somewhere and you might ask employees randomly or at certain times during the week. They simply put their finger on it, their two fingers on it, their index finger takes a fingerprint so we know which employee that is. And the middle finger sits over a screening device that can detect alcohol and the amount of alcohol in their system in 12 seconds. So this is a great way for us to identify if people are either using on the job, coming in still impaired from the night before. It just can help us determine and have a higher incidence of understanding how prevalent is the problem, since up to 17% of the people in the workforce are probably having problems with alcohol use. I'm going to just pivot to our last and I think most exciting technology, and that's that we use virtual reality, as I mentioned earlier. Our app allows people to go in, they can pick any group that they want to participate in. We have groups 7 days a week, multiple times a day. We can have groups just for veterans. We can have groups just for Native Americans. We can have groups just for moms with young children. We can have groups for pilots, right? We can have groups for people where you're gathering enough people together who have more shared experience than simply just struggling with alcohol. And that makes the groups even more effective because they can really relate to one another better. So being a national company and being able to provide care in this way, we can aggregate people in groups and have them pick which groups they want to participate in. They literally tap the group that they want to participate in, they put on their VR headset, and they're in the group. We've made this a seamless process, and we've built our own application in VR. So when people are in VR, they're literally an avatar, right? They come in, they create their own avatar, they can look like what they want to look like, but most importantly, they're completely anonymous. They can even mask their voice. So you could be sitting next to Cher, you wouldn't know it was her. You know, everybody that's in the room is completely anonymous. So it's just a wonderful thing because people feel so much more free to talk about the struggles that they're having and to be honest about what's happening for them. And we
I think
found
it's,
this really impactful.
yeah, I would think that it'd be so much easier for the injured worker or person to be able to say, you know, I'm really upset with myself. I had a relapse this weekend, blah, 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 because they're not really looking at a person, right? They're just talking in their group in order to get the group treatment that they're doing. And I just think it's really fantastic because they can really be open. Nobody
Yes.
wants to look like they failed in public. So here they've got an avatar. They could be a woman instead of a man or whatever. It's
Exactly.
fantastic.
It is, and they're home, right? They didn't have to drive to a meeting, go in a cold basement. You know, they're home on their couch. If their kids are there, they don't have to leave. So it's really portable. You know, we think that this would be great for truckers. They can take this with them. You know, you can take it with you anywhere. If you've got Wi-Fi, you're in. So, and this headset, by the way, is completely included in a kit that we send people. I'm going to show you the kit shortly. I just briefly want to touch on our success rates. What we have found so far is that there really are 5 major components of our program, right? We monitor people's alcohol levels. In the early days of our program, we were using breath alcohol measurements. We monitor how well they're taking their medications. Are they compliant with that? We monitor if they're taking the nutrients that we send to them. We monitor how often they're participating in our VR groups. And also, are they engaged with our providers? Are they regularly meeting with their doctors, their nurses, their peers? And we found that patients who were doing at least 3 of these, it didn't have to be all, but if they were doing even just 3 of these things, 86% of them were meeting their alcohol use goals. It was amazing. We found that when people were doing 4 of these things or more, they were 100% meeting their goals. So really, we call these the things. We say to patients, if you do the things, you will get better. And it's just been proven over and over again. And my co-founder is a statistician. These statistics are significant, down to p.01. And what that means is there's less than 1% chance that these numbers are erroneous. So this is highly significant, highly statistically proven data. I'll pivot
And
now just to talk. Yeah.
I think the other thing about this is these things are easy to do, right?
Yes.
Because the monitoring their alcohol, that's easy, right? It's a matter of touching something or wearing a watch, taking medication in the morning. I mean, these are easy things. If you're going to be in a group, you could do it at your break or, at lunch, at home, on the weekend, really easy. I think
Easy.
this can really change the way that people have treatment for alcoholism and really change our workforce.
Exactly. That's exactly right. And we want to make this easy. We want to make this easy for employers. We want to make this easy for employees. The way I like to think about it is these are uncomfortable conversations, right? HR people don't necessarily want to tap an employee on the shoulder and say, I'm worried you have a problem. That's very awkward. And employees don't want to have the conversations with their employer for the same reason. They're scared to bring it up. They're afraid they might lose their job. So we've made this so anonymous that what we do is we give every employer a toolkit so that they can make this widely known to patients that this is available to them and their families. But the employee and the employer never have to have a conversation about it. The employee can log into our program directly. They get signed up and they meet with one of our nurses and have a conversation about whether they're a good fit for the program. 95% of patients who call us are a good fit for this program. So we can then get them in. We overnight a kit to them, and I'm going to show you the kit in just a moment. But that kit includes all of the things that they need to be able to start the program. And they get this the next day. We give them a tablet if they don't have one so they can do their telehealth sessions with their doctors and nurses. We send them that via our headset. We also send them a blood pressure cuff so that we can monitor their blood pressure and heart rate as they're coming off of alcohol and make sure that they're safe. We have nurses checking that around the clock. We have the smartwatch that I mentioned. We send them the DNA testing kit. That's included as well so that we can get those genetic results back and even fine tune their medications further as soon as we know what's most ideal for them. We check for pregnancy, of course, because that changes the treatment in pregnant women. We also send them drink substitutions, alternative options for alcohol use so that they can wean off of what they've been drinking and onto something that's a substitution for it. And it really helps them with cravings. It's very impactful. And lastly, we send them the first 3 months of nutrients so that they can get started right away on the nutrients and start feeling better very quickly. The bar has been very low, right? The bar for success with rehab has been 13%. And we have really raised the bar now to, at 86%, because all of these different components of treatment, care coordination, treating patients with telehealth, which keeps them engaged in treatment, using these nutrients, doing peer support that's very accessible electronically, it changes the game. And we really think that getting this widely available to employers can be very effective. And as you're dealing with people who have already had a workplace injury, knowing that, offering them information about this, you don't even necessarily have to say, I suspect you have a problem. It could just be, I think that every person who has a workplace injury should get a little card or a pamphlet or something about this so that if they have a problem, they could go home, they could easily call, and the employer doesn't need to know because this is covered by their insurance, and the employee didn't have to have that really difficult discussion. But this way we prevent the next workplace injury from happening, and I think that's really important. We've just partnered with the Hartford. The Chief Medical Officer of the Hartford, Dr. Seidner, is having regular meetings with me because we're going to be implementing this for workers' comp programs all across the country that are funded by the Hartford. And I'm very excited about that partnership. And I think that we want to continue to build on these relationships. So it's been a real pleasure to meet with you all. And I'm happy to take a few more questions if we have time, and also happy to send answers to you.
We do have a few more questions. So
Great.
Get to those for you. One of the questions was on the medications, not the supplements, but the medications. Are there side effects?
Different medications can have different side effects. The ones that we're choosing, really patients don't describe having side effects. Naltrexone is one of the ones that we often use to help people avoid drinking. In general, they do very well on that. We don't really see side effects from that. Magnesium, that nutrient that I was telling you about, that can cause diarrhea in some people. So we just simply adjust how much magnesium that patient is taking. Neurontin, which is a medication that we use to help their brain not feel the loss of alcohol very much, can make people somewhat sleepy. That's a bonus though, because generally they struggle with sleep. So sometimes, yeah, you get a twofer there, So we're always in touch with the patient and meeting with them regularly so that if they are having any side effects, we can pivot because we have 30 different things to pick from.
So the next question is there a difference in the stats between using hard alcohol and consuming beer?
The only difference really is the total amount of alcohol consumed. So we convert the alcohol they're drinking into standard units. One beer that has 5% alcohol, a 12-ounce beer, is considered to be one standard drink. 1.5 ounces of hard liquor is considered to be one standard drink. So we add up for the patient. If they're consuming 20 beers, that's 20 standard drinks. Or if they're consuming, 20 1.5 ounce shots of vodka. That's also 20 standard drinks. And then we decrease their alcohol based on their standard drink volume.
Got it. So the next question I have, and I don't know if you can actually give an answer to this, because I imagine it depends on the size of your program with the company, is what is the average cost of the program for somebody?
Yeah. So through insurance, insurances are paying us $20K to provide this care for the entire year. So we're considerably less expensive than detox, which is typically $5K, and rehab, which is typically $30. That $35,000 is for, a month, right? And for our program, it's a year of care for 20, and it's paid for by insurance. We're getting in network right now with Optum, Cigna, Blue Cross, a variety of different insurers across the country. And that we'll just continue to be growing that. So we're eager to work with you. And if you have an insurer that you often work with, we'd be very pleased to meet with that insurer quickly and get in network with them so that we can be providing benefits to the employees of the company that you work with.
And if somebody wanted to do this on their own because they just realized, you know what, I just started drinking too much. Do you have a payment program or something for individuals who want to do this?
We absolutely do. In fact, we give a discount when people are paying out of pocket because we want to make this accessible. So we charge $15,000 for the year for people who are paying out of pocket, and we absolutely can do that as a payment plan. That's not a problem. We're happy to accommodate this to make it accessible for anyone.
And of course, this program is available for non-working teens and adults.
Yes,
yes,
almost. Yeah, we can take care of anyone. Yeah.
That's what I figured. Well, somebody said this is fascinating information. Thank you for sharing. So let's see if there's anything else that we want to ask. I'm sorry I made somebody cry at the beginning, but it's real life. And I'm just so grateful that you have this program, because had this program been available the day that I had my son in the car, it would never have happened, because I would have been able to set my son down and say, there's a program, you could do it at home. You're not going to be locked up. You're not going to be alienated. You're going to be able to do these things, and there'd be no stigma. And so I just really believe that this program is outstanding for so many reasons. But the fact that it's going to give people back their lives is incredible. The fact that our employers are going to get their employees back that do a great job for them, and that, hopefully we'll be able to reduce the cost of workers' compensation. So on that note, we are at the end of our program. I do want to say however, that if you are trying to get records for alcohol and drug treatments, that you do need to use a specialty form on that. MacroPro's multi-purpose authorization form has the specialty lines on it. You need to make sure that the injured worker initials those as well as signs the bottom of the authorization form in order for us to gather those records for you. Until the next time, we will see you at MacroPro and Friends. Bye-bye now.
Thank you. Bye-bye.